Alzheimer's disease is progressive gradual loss of neurons in the entire cerebral cortex. Symptoms progress over 5 to 10 years until the patient is unable to perform daily activities. The loss of neurons actually causes the brain to shrink. You will see postmortem evidence of atrophy of the cortex, thinning of the gyri, widening of the sulci, and ventricular enlargement. The histological hallmarks of Alzheimer's disease is plaques and tangles. The plaques are caused by deposits of aggregated amyloid beta proteins, and the neurofibrillary tangles are caused by aggregates of microtubule binding tau proteins. The aggregation of beta amyloid plaques occurs in and around neural synapses in the brain. These plaques are physical structures that take up space. You can think of them like a deep beaver's dam in that they block the kinetic flow of neurotransmitters across the synapse, thereby blocking communication between the neurons. Research is showing the appearance of beta amyloid plaques to be the initial event in Alzheimer's disease. Since these plaques are not supposed to be there in the synapse, they trigger an inflammatory response, summoning microglia cells to the area to clear them away. Unfortunately, there comes a point when there are more plaques than the microglia cells can manage to phagocytize. The entire problem with accumulation of beta amyloid plaques begins with abnormal cleavage of amyloid protein precursor proteins normally found in the synaptic membrane of neurons. Normal cleavage of this precursor forms a harmless soluble peptide. Soluble is the key word. They just dissolve in the surrounding interstitial fluid. Abnormal cleavage forms an insoluble amyloid beta peptide that aggregates. I posted a very good video demonstrating this abnormal cleavage called Plaques and Tangles. I hope you take the time to watch it. Formation of tau tangles. Tau proteins hold intracellular microtubule networks together. Neurons use these microtubules to transport stuff around, particularly transporting vesicles and enzymes to the axon terminal so the neuron can produce neurotransmitters. In the case of Alzheimer's disease, the tau proteins become hyperphosphorylated and can no longer hold the microtubule network together. The tubules unravel and tau proteins get tangled up inside the neuron. The loss of the neurotubule network prevents axoplasmic transport, which eventually leads to the death of the neuron. The video I mentioned in the previous slide called Plaques and Tangles also does an excellent job of demonstrating this process. Alzheimer's disease dementia. Post-mortem histological specimens have demonstrated that the amount of neurofibrillary tangles found in the brain tissue of a deceased Alzheimer's patient is directly proportional to the degree of dementia that developed in that patient. Therefore, it has been concluded that the more tangles in an Alzheimer's brain, the more severe dementia they develop. Acetylcholine is a very important neurotransmitter in learning and memory. Research has found that the amount of acetylcholine in the brain is proportional to the brain's ability to learn new things and recall memory. In addition to space-taking amyloid beta plaques blocking neurotransmitters moving across the synapse, they also block the activity of acetylcholine esterase. Acetylcholine esterase is required to break down acetylcholine into acetyl-CoA and choline. In normal functioning synapses, the presynaptic neuron will reabsorb the choline to synthesize more acetylcholine neurotransmitter. Blockage of acetylcholine esterase by the amyloid plaques decreases choline recovered by the presynaptic neuron and therefore reduces the amount available for learning and memory recall. Progression of Alzheimer's signs. I'm going to take the time to read all these signs of Alzheimer's disease. I know you can read them yourself. However, one of the reasons I'm recording these PowerPoints are for those students who want to hear the information in addition to reading it. The main thing I want to point out with these signs is that the progression of Alzheimer's is memory loss preceding personality changes. I'm mentioning this because the next condition we will cover, frontal temporal lobar degeneration, has the progression of signs opposite where personality changes precedes memory loss. So going down the list, number 1, memory impairment, just difficulty remembering events. Something as simple as just remembering where you went the day before. Number 2, difficulty concentrating, like planning or problem solving. How are you going to plan your day out? Are you going to go to the bank first and then to the grocery store and get milk, or vice versa? Problems finishing daily tasks. This is not a situation where the person has planned more than they can get done in one day. It's where they have a normal routine and they just can't get everything done. 4, confusion with location or passage of time. We had a situation in our office where one individual was developing Alzheimer's, and my CA saw the person drive around and around the office and finally parked because she was a little confused of where the office was located. 5, visual or spatial difficulties. Parking is a good example. Maybe for years, a person is parked in the garage and then they just can't judge getting in there, or getting lost or misplacing items. It's not so much like you forgot where you put your keys. It's maybe you put your keys in the refrigerator, or you just did something really weird with them. Or when you did find them, you look at the keys and you can't even remember what keys are for. Number 6, language problems. This is where the person is finding difficulty finding the right word to speak or in writing. This is where the symptoms or the signs, the disease starts to really progress, and they become almost withdrawn because they just can't say what's on their mind. They can't get the words out. 7, using poor judgments in decision. For example, when they need to cross a highway and they see traffic coming, can they judge if they have enough time to cross the road? Or when they're washing a knife and they wash it with the blade towards their hand instead of away from it. Number 8, withdrawing from social events. This occurs as the disease progresses because they are losing memory. They are finding it difficult to find the words, so they just are not comfortable around people and they become withdrawn. Number 9, changes in mood, personality changes, and depression. That's where the disease is pretty advanced. A person can become very angry and violent and very fearful during this time. Number 10 is dementia, and that is really the advanced stage of this condition. And dementia means that they have lost pretty much all short-term memory, all long-term memory. They really have no clue of who you are, who the caregivers are, where they are, why they are there, and it's really a very difficult time for them. Number 11 is where they are non-communicative. I can't say that word very well, and I'm having trouble communicating. They just no longer talk. They're not able to talk anymore. Number 12, they're totally immobile, and 13 leads to death. Diagnosis of Alzheimer's disease. The early stages of Alzheimer's disease can only be diagnosed by clinical signs. There are no lab tests specific for this condition. Lab tests are all done to rule out differential diagnoses. MRI can show brain atrophy, but only in the advanced stages. By this time, the Alzheimer's patients required full care. PET scans, positronic electron tomography scans, use radioactive tracer molecules that bind to beta amyloid proteins. This exam is useful in diagnosing early Alzheimer's. However, for this diagnosis to be accurate, the patient must be exhibiting early signs, clinical signs of Alzheimer's at the same time. PET scans have an 80 to 90% accuracy in diagnosis in individuals with advanced Alzheimer's. Currently, the only definitive diagnosis of Alzheimer's is confirmed on autopsy with post-mortem examination of brain tissue. And as a side note, I want to mention that some research links aluminum toxicity to brain tissue in Alzheimer's disease. Alzheimer's differential diagnosis. Other conditions that can affect memory or cause dementia that are the key signs of Alzheimer's disease are stroke, trauma, tumors, Parkinson's disease, supranuclear palsy, dementia with Lewy bodies, Huntington's disease, hypercortisolism, and frontotemporal lobar degeneration, which is the condition that we'll be covering next. Alzheimer's etiology. Most cases of Alzheimer's disease is idiopathic. However, research is showing that 5 to 10% of cases have a genetic component. Almost all individuals with trisomy 21, Down syndrome, will present with Alzheimer's before age 40. Alzheimer's is extremely prevalent. As many as 26 million people affected worldwide. Alzheimer's will affect approximately 5.8 million Americans aged 65 or older in 2020. The CDC predicts 1 out of every 3 seniors will die of Alzheimer's disease. The U.S. numbers are expected to increase to 14 million by 2060 and 1 in 85 globally by 2050. This disease is more frequent in females, mostly because females typically live longer than males. Typical onset is over the age 65, but symptoms of early onset can appear before 60, but rarely before age 50. Frontotemporal lobar degeneration is a group of disorders that affect the frontal and temporal lobes. This condition is marked by aggressive progressive loss of neurons in the cerebral cortex of the frontal and temporal lobes only. Onset generally occurs around 40 to 45. However, it can manifest at a younger age. In fact, it's considered the more common cause of early onset dementia, where Alzheimer's is the most common cause of late onset dementia. This condition can be inherited, sporadic, or caused by an infection. This condition is often misdiagnosed as a psychiatric disorder or Alzheimer's disease in the early stages. We're going to cover why it's confused with Alzheimer's next. How to distinguish frontotemporal lobar degeneration from AD. As I mentioned in the previous slide, FTLD is often misdiagnosed as Alzheimer's because it manifests signs very similar to Alzheimer's. The big difference is when those common signs present themselves within the FTLD patient. A person with frontotemporal lobar degeneration will manifest personality and behavioral changes before they have any memory loss. This is the opposite of Alzheimer's. Alzheimer's patients present with memory loss first and then later on show personality changes. Persons with frontotemporal lobar degeneration will also lose the ability to communicate and understand language, called aphasia, early on in the disease process, whereas in Alzheimer's, the patient will not present aphasia until the very end stages of the disease. FTLD patients will also develop dementia, and some will also develop movement disorders. There are 2 common types of frontotemporal lobar degeneration, and both are associated with abnormal cellular inclusions of specific proteins. These inclusions kill the neurons. One of the frontotemporal lobar inclusions has what's called TDP43 protein inclusion bodies, and the other has tau protein inclusion bodies. Both Alzheimer's and frontotemporal lobar degeneration are also categorized as tauopathies because their conditions are associated with abnormal tau proteins. The only named frontotemporal lobar degeneration disease we will cover is Pick's disease. Pick's disease is a type of FTLD with tau protein inclusion bodies. The hallmarks of Pick's disease are Pick bodies, which are smooth, contoured tau protein inclusion bodies within the infected neuron and lead to atrophy of the frontal and temporal lobes. Amyotrophic lateral sclerosis is also known as Lou Gehrig's disease. It is characterized by progressive death of voluntary motor neurons. Most, but not all, forms of ALS are due to toxic protein accumulations within the motor neuron. ALS affects both upper motor neurons in the cerebral cortex and lower motor neurons in the brain and spinal cord. The condition got its name from the degeneration of the corticospinal tract it causes. ALS results in denervation of muscles, which leads to profound muscle weakness. What does ALS look like? Histologically, you'll see lesions of the lateral corticospinal tract in the cord and the anterior horn. On imaging, you'll see lesions of the corticospinal tract on MRI in the brain. What is ALS prognosis? The prognosis of ALS is not good. The condition is progressively debilitating, and eventually the patients become non-ambulatory. Patients lose their ability to communicate and will require breathing support. Near the end stage, the patients will require a feeding tube and a ventilator. Most medical information states that ALS is fatal 3 to 5 years after symptoms begin. However, about 10% survive 10 or more years. You'll see images of long-term survivors in this PowerPoint. Currently, there's no cure, and the only treatment is supportive care. Most patients with ALS succumb to pneumonia. ALS etiology. Most cases of amyotrophic lateral sclerosis are sporadic, and only about 20% have a familial autosomal dominant link. ALS is considered rare, affecting only 1 to 3 people per 100,000. The typical age of onset is 40 to 70 years old. However, as with most conditions we cover, ALS can manifest earlier in the ages of 20 to 30. Statistics show that ALS affects more males than females. I mentioned before that I'm going to show photos in this PowerPoint of people who have lived well beyond the 3 to 5 year mark. However, I have this one incident where this actor, Lane Smith, died 1 year after he was diagnosed with ALS. So I'm just stressing that this condition is very different in each individual. What are ALS early symptoms? Amyotrophic lateral sclerosis symptoms varies between individuals. The overall initial symptom for all ALS patients is muscle weakness, and all ALS patients will develop the symptoms listed below. However, the order in which each patient develops these symptoms will vary from patient to patient. Initial muscle weakness can be so subtle that it's easy to overlook. Some patients initially develop random muscle rigidity and cramps. Some will initially develop hand and or arm weakness. The first indication may be noticing difficulty buttoning their shirt or turning the key in the lock, but more commonly it's dropping things. Some ALS patients may initially develop leg and or feet weakness. They might notice awkwardness when walking. They might find that they are beginning to trip a lot or stumble a lot. Some will notice weakness in their throat or mouth or tongue, manifesting as difficulty swallowing, known as dysphagia, and difficulty forming words, known as dysarthria. My cousin, who died of ALS in 2015, her very first symptom was difficulty swallowing. On this slide, you see a picture of Steve Gleason. He was the safety for the New Orleans Saints between the years 2000 and 2000. And you'll see on the next slide, this young man was diagnosed with ALS. ALS progression of symptoms. As amyotrophic lateral sclerosis progresses, the most visual sign will be the significant muscle atrophy, making the individual look extremely lean. Muscle weakness will progress so that all ALS patients will become non-ambulatory. All will experience muscle cramps, spasms, rigidity. The dysphagia worsens to the point where they may be on thickened liquids in a pureed diet to an eventual liquid diet through a feeding tube. The difficulty breathing, dyspnea, will also require the use of a ventilator 24/7. Here's the photo of Steve Gleason. He is still alive, but he was diagnosed with amyotrophic lateral sclerosis in 2011. And I do have a video linked to his story in your folder in Schoology. Cognitive and sensory function unaffected and some muscles spared with amyotrophic lateral sclerosis. As mentioned previously, ALS only affects voluntary motor neurons. The mental status and cognitive abilities of a person with this condition typically remains intact. Only a small percentage may develop dementia in the late stage. Again, ALS only affects motor neurons, so a person's sensory input is not affected. They can still feel pain, temperature, and touch. An interesting aspect of this condition is that ALS spares extraocular muscles. With the advent of technology, many people are able to communicate in this advanced stage of the disease through eye movements. Another interesting fact is that most ALS patients retain control of their bowel and bladder function. Here's a photo of Stephen Hawkins, a theoretical physicist and cosmologist. He was diagnosed with this very young in life in his 20s and lived 50 years with the condition, and clearly it never affected his cognitive abilities. How is amyotrophic lateral sclerosis diagnosed? As with every condition we have covered so far in this lecture, there is no definitive lab test to diagnose ALS. Early diagnosis is primarily based on a clinical history of mixed upper motor neuron and lower motor neuron symptoms and neurological exam verifying mixed upper motor and lower motor neuron findings. Clinicians will look for evidence of muscle weakness, fasciculations, atrophy, and spasticity, and perform lab tests to rule out differential diagnoses such as MS, polio or post-polio syndrome, that if it wasn't identified in the history, multifocal motor neuropathy, and Kennedy's disease. Again, if these were not revealed in the history, then a test would be performed to rule them out. The early symptoms of ALS are very similar to MS, so keep that in mind when we cover MS next. On this slide, we have a picture of Jason Becker. He's a songwriter and a musician. He was diagnosed with this condition very early on. He was actually the lead guitar for, oh gosh, I forgot the rock star's name. Anyway, he was not able to go on tour with him because of being diagnosed with amyotrophic lateral sclerosis. Oh, I remember, it was David Lee Roth. Multiple sclerosis. This photo represents a group of people that participated in a fundraiser for multiple sclerosis. As you can see by the way we are bundled up, it was very cold that morning. About 4 times a year, I would have a special fundraiser day in my office where all services were complimentary for a donation to the cause I was supporting. That included services for new patients, which I limited to a complete exam and x-rays if necessary. Multiple sclerosis was one of those causes. I also did United Way, pregnancy centers, and the SPCA. It's a great way to be involved with your community and also support some of your favorite charities. What is MS? Multiple sclerosis is an autoimmune disorder. The body begins to make antibodies against myelin. This condition damages myelin but preserves the axon. It is considered the most common demyelinating disorder. MS primarily affects neurons in the central nervous system and 2 cranial nerves, cranial nerve 2 and 5. MS is frequently associated with affecting the optic nerve, cranial nerve 2, causing optic neuritis and affecting vision. MS can also cause demyelination of cranial nerve 5, the trigeminal nerve, but this is not as common. Trigeminal neuritis is also known as tic douloureux and causes severe facial pain. MS etiology. The actual cause of multiple sclerosis is still unknown. Multiple sclerosis is not lethal, but it can be debilitating. Unfortunately, MS is relatively common, affecting 1 per 1,000. This number comes out of the Guyton textbook. Every other source I checked, such as the National Institute of Health or the CDC or the National MS Society has a different number, so we'll just stick with the number mentioned in the board-approved text. Women are affected 2 times more than men. The common age of onset is between 20 to 30, but again, I must reiterate that it can occur at any age. However, it rarely develops in childhood or over the age of 50. What is the geographical risk of MS? Multiple sclerosis has widely been associated with individuals living above the 40th latitude in North America and Europe. It seems the further away from the equator one lives, the greater the risk of developing MS. Some research believes it has something to do with not getting enough vitamin D. Characteristics of MS. First, I must say that the progress, severity, and specific symptoms of multiple sclerosis are unpredictable and vary from one person to another. The most common type of MS is RRMS, relapsing, remitting, multiple sclerosis. This type of MS has periods of exacerbations and remissions of symptoms. The exacerbations are unpredictable episodic attacks of neurological deficits where the affected person's body is actively making antibodies that are damaging the myelin. During periods of remission, the body stops making antibodies against myelin, giving it a chance to regenerate. The most common scenario is not all of the myelin regenerates completely, leaving the patient with some residual neurological deficit. What does MS look like? The central nervous system scarring caused by multiple sclerosis can be seen on MRI. The word sclerosis actually means scar. If a person has had more than one period of exacerbation, an MRI may show multiple areas of demyelination with reactive gliosis. I say may show astrogliosis because it takes time for the scars to appear. The gliosis can be visualized in white matter of the brain, spinal cord, and optic nerve. What are the results of MS? The results of demyelinization is decreased rate of communication between neurons. It slows down the motor efferent signals from the brain down the spinal cord to the peripheral neuron, and the sensory afferent signals from the spinal cord up to the brain. MS signs and symptoms. Unilateral visual impairment is often the first sign or symptom of early MS. The symptom is an indication of optic neuritis associated with demyelinization. Other symptoms such as ataxia, nystagmus, and ophthalmoplegia may show up as a result of affecting the myelin around axons running through the brainstem. Ophthalmoplegia is eye muscle weakness. This sign symptom is one that would distinguish MS from ALS because ALS patients retain eye muscle strength. MS signs and symptoms. Multiple sclerosis will at some point involve sensory and motor impairment of the trunk and limbs. MS patients experience muscle weakness and spasticity. ALS patients also experience muscle weakness and spasticity. MS patients can experience urinary incontinence during an exacerbation phase. If you remember, ALS patients typically retain urinary control. MS individuals are extremely temperature sensitive. They suffer when conditions are hot or very cold. Heat will exacerbate all symptoms because it impairs communication of demyelinated axons, and cold temperatures will increase the spasticity of muscles. Diagnostic test. There is no single one test that can definitively diagnose multiple sclerosis. MS is diagnosed by a combination of a detailed history, complete neurological exam revealing positive findings, ophthalmic exam with a slit lamp looking for optic neuritis, a spinal tap, also known as lumbar puncture, showing elevated immunoglobulins in the CSF, while the blood work shows normal immunoglobulins in the serum. And finally, lesions can be seen on MRI, but typically a person is diagnosed with MS before the lesions are noticed on MRI. Clinicians must also rule out other differential diagnoses such as amyotrophic lateral sclerosis, myasthenia gravis, stroke, viral infection, and inflammation. Research. A research study in 2007 indicated high titers of antibodies for Epstein-Barr virus, B2LF1, is a strong predictor of multiple sclerosis. Another research study suggests high levels of vitamin D show a lower risk of developing multiple sclerosis. And that would have something to do with geographical risk, where they state that people that live further away from the equator do not get enough vitamin D. Prognosis and treatment. The prognosis for multiple sclerosis is not bad. Currently, there is no cure, but they can expect a normal lifespan. Most MS patients remain ambulatory, and only about 25% require a wheelchair during exacerbation. The current treatments for MS are immunotherapy, anti-inflammatory, and pain relief medications. MS patients also benefit from physical, speech, and occupational therapy. And of course, but definitely not least, MS patients benefit from chiropractic adjustments. I've treated many MS patients in my practice. I believe I mentioned that in the instructional video. Chiropractic treatment or chiropractic adjustments are absolutely amazing in helping the well-being of an MS individual.